Hey guys, welcome back to the channel. I'm Dan. I am founder of the PACES Academy, and today I'm going to be sharing with you a lecture that I gave in the very first diet of the PACES Academy. So that was this year, and it's going to be covering the whole of the neurology station, basically. So going through all of your PNS, starting with the exam, thinking about all the signs, thinking about all the special tests, and trying to give you guys a way of thinking about the neurology exam. The reason why I'm doing this is because this, in the feedback in the PACES Academy, was one of the most common things that people were constantly talking about as being really helpful. And so far, in our very first diet, we've had 6 results, and 6 out of 6 people have passed 100%. If you compare that to the national averages of about 50%, it is wild how effective the PACES Academy has been. And shocked even myself. So you can join. There is a link below. But before you start looking at this lecture, big disclaimer: I am not a neurologist. I am a registrar, and I just teach PACES. So yes, have a look at it and use it. It's all pretty good in my opinion, but I'm certainly not a neurologist. I'm not an expert, but I think it's been very helpful for the people that I have taught. But another disclaimer: remember, it's not all about knowledge. I've talked about this in my other webinars, in my other YouTube channels, YouTube videos, sorry. It's not just about knowledge. This is a bit of knowledge, but this is actually also a skill. The skill here is trying to learn how to think about the approach to the neurology exam. Obviously, you also have the skill of examining the patient, and we can't do that in the PACES Academy. There have been some comments that you need to just practice. 100%, you have to practice. The PACES Academy cannot do that for you. But what it is hopefully a way of giving you a map as to how to approach all of these stations. Use this resource. It's, I think, a really good lecture. It's very long, I think an hour and a half or something. So make sure you pause it, come back to it, share it with friends, get a cup of tea. But yeah, hopefully it's a really useful resource. And if you want to find out more, have any questions, put them in the comments. I do reply to comments, and you've got YouTube 15% off if you would like to join the PACES Academy, where I work with a load of people just like yourselves in the same position, trying to get through this exam. And like I said, we've had 6 out of 6 pass in the last diet, which was our very first launch diet. I hope this is useful, even if you don't join. So good luck with your exams, good luck with your revision, and I'll see you in there. Yeah, I'm just going to do screen share, and I'll just... Okay, so we'll make a start. Thanks very much for joining. And today we're going to be just talking about an approach to the neurology station for PACES. Obviously, I'm going to make the disclaimer that I'm not a neurologist, but I would maybe argue that hopefully that's meant that I've had to think about these things a bit more, and hopefully I can break it down into maybe a more straightforward sort of way of thinking about it. I think the main objective today is to try and outline the way to think about the station rather than learning all the knowledge. I want to try and get across that what certain signs should be pointing you into which direction, and at the end we're going to go over a full sort of like decision tree, which hopefully outlines that. The way we're going to do that is to go through the actual neurology exam, and when we're talking about it in this talk, it's going to be the upper and lower limb. We will do the cranial nerve separately, but we're going to talk through the exam, so your inspection, tone, power, all of that, and then we're going to go, and I've tried to get as many examples of each sign, so that even if we, it's a bit of a longer talk today, but even if we don't, use all of those today, or that's not useful for you today, hopefully, if you need to come back and look at things, you have all the examples of signs in here, which are all essentially from YouTube. But I wanted to try and get all of the signs in so that this is a kind of resource for everyone. And then as we're going through the neurology exam, there are 3 questions that you should be asking of yourself when you're examining these patients. So the first one is the lesion upper or lower motor neuron lesion? The second one is, where exactly is the lesion? And then the last one is, what is the etiology? And that's essentially, which list do I put in at that point? With regards to those questions, we are definitely going to address the first 2 questions. We will touch on the etiology a little bit, but that is again going to be in another talk, just because otherwise this talk is going to go on forever. And then the idea is that we're going to review a decision tree. right at the end and kind of hopefully recap and demonstrate what we have actually mapped out through the teaching is the idea. So that will be the aims of today. And like I said, I'm not a neurologist, but also what I want to try and get across is the way to think about this, the approach rather than the actual content. And there's not very much about each condition. It's more about each syndrome. And I want you to think about what clinical signs point you towards that syndrome. And then in another talk, you'll learn, and you know a lot of this already, all of you, but you will know the potential differentials or etiologies of that syndrome. So for hemiparesis, for example, then you insert a list. And that's how we're going to structure this. So try and keep it nice and simple and give you the scaffolding. And then you guys can go away, do your reading, do your practice, and build up your own lists and practice your presentations. And those are things that we will build upon. But these are the foundations today. So the idea, and the only reason I'm putting this in is because I have spent a lot of time talking about practicing over content. But I think this is essentially going to be a map. So when I was a student, I've used the example that when I was traveling from from London to Nottingham, I at first needed to look at the map. I needed to consult the map the first few times, but then after practicing it for many years, I didn't need to think and I just did the whole thing perfectly. And that's exactly how I want this to be. For some people, they'll be very good at neuro, but like I said in the cardiology teaching, it's not really possible to be good at all of these stations. And so some of this is going to need to be recapped and you may be rusty. And the idea is that this is the map for the neurology station. And you guys are going to go away and practice that route and practice different routes. And hopefully that is how you're going to build up so that you can nail your paces, basically. And yes, so the neurology exam. So I was taught at uni, in the pouring rain she came. And I've adapted it slightly to in the pouring rain came she. And the reason for that is that I think there is much more benefit from doing the coordination before the sensation. And I don't know if that's commonly taught or, but I think at my uni, at least, we did coordination after. The issue with the sensation exam, as you guys may know, is that it takes quite a long time. And arguably, there is not all that much diagnostic benefit from it. And I'm going to make that argument later on in the discussion. But, you know, demonstrating a patient having ataxia, I think is far more important in a PACES station than demonstrating that they have intact proprioception, but have some slight light touch, problems. I don't think that is actually that relevant. And arguably, you're going to hopefully have an idea of the pattern of your neurological deficits before you get to the sensation. So that's why we switched those around. So we're going to do inspection, tone, power, reflexes, coordination, sensation. I've also made the argument that actually reflexes could potentially come before power. I wouldn't do this just because it's not really conventional. But as you'll see, inspection, tone, and reflexes are going to be informing that very first question that we're asking. Is this upper or lower motor neuron? Whereas power is kind of normally demonstrating more where the lesion is rather than necessarily pointing towards whether it's upper or lower. You get weakness in both upper and lower motor neurons. So it's not deciding where that first question. So that's why I put that in there. But yeah, so that's what we're going to start with. So we'll start with inspection. In PACES, so inspection is a little longer just because I'm aware that in PACES there are some very specific conditions that come up far more than they would in real life. And there are also some things that may come up that actually you have never thought about before. And so what we're going to do is do the classic signs, then we're going to do the special tests and what you may see on an examination of those special tests, because normally you do them right at the start. And then we're also just going to touch upon sort of movement disorders, because I remember just like having a panic about a week before my exam and trying to get as many movement disorders in. So what I want to do is just give you an idea of how to approach someone if they do happen to have a movement disorder. I think you'd be quite unlucky. When I say movement disorder, I don't mean Parkinson's or myasthenia gravis. I think that's quite likely to come up and you should definitely prepare for that. I mean things like chorea or athetosis or pseudo-athetosis. But I guess it's helpful to just signpost and have an idea of what that looks like and how you should be approaching that now rather than a week before the exam like I was trying to do. Obviously, muscle wasting, fasciculations, and pronator drift. It's not necessarily a special test, but you do it right at the start. that those are going to be your main three things you're going to see on inspection. But I would argue that actually inspection is the main thing, and I would say this for all of PACES. Inspection is going to be the thing that tells you the most. So even though I've only put those three things there, for example, if I was holding my arm like this in a flex position, or I was supporting my arm when I was sitting up in the chair, that may be a sign that you've inspected of me, and I'm demonstrating that I have weakness in a limb, or I may have spasticity in the limb, or you may inspect that they have a load of orthotics and things like that. So inspection is far more than this, but we're just going to focus on the neurological signs. And I would highly recommend doing as much inspection as possible. I think you're going to get 80% of all of your signs is going to be from inspection rather than auscultation or palpation and things like that. So starting with muscle wasting, this is obviously a sign of lower motor neuron pathology. And when we're thinking about where the muscle wasting can be, and this is how we're going to do this, is hopefully just keep it nice and simple. We're thinking proximal or distal. And so depending on where that muscle wasting is, you may think about different things. So obviously on the left, that patient has got wasting of their thenar eminence on their right hand. Hopefully you can all appreciate that. So that's very commonly seen in carpal tunnel, whereas the gentleman on the right, he has got quite significant proximal quads wasting. Often these patients, it will appear that their knees are very big, and they may look like maybe arthritic knees, but actually the knees are normal, and it's just comparatively that their quads are very small. And so that gentleman has got inclusion body myositis. So just again, getting into the practice of thinking about the pattern, and we're going to be talking about patterns quite a lot today. The next sign is fasciculations. So fasciculations are these little spontaneous flickers of muscle movement, and these are very, very classical of lower motor neuron pathology. In particular, when you see fasciculations, you want to be thinking about motor neuron disease. So amyotrophic lateral sclerosis is the sort of formal name. But you, with motor neuron disease, the key thing is that you may see upper and lower motor neuron signs. So you may not, because sometimes it's difficult and they don't present early, and I don't exactly know the reasons why, but basically, motor neuron disease is on your mixed list of signs, but fasciculations are very, very classical in motor neuron disease. Fasciculations can be normal. So I don't know if anyone has felt tired, or, I get a twitchy eye sometimes. I get a twitchy shoulder when I'm really tired, or when I used to drink and I was hungover, those kind of things. So fasciculations can be normal, but we're thinking about lower motor neuron pathology. And with a few of these signs, I think it's always helpful to try and think about why it actually happens. So because the lower motor neuron is so damaged, it is now basically has an unstable terminal. And so this is spontaneously depolarizing because of the damage. And then I think there's also the body's trying to re-innervate the area. And this is a process called sprouting. And this also contributes, these new neurons that are trying to re-innervate the muscle in the area are also quite unstable. And so you've got two reasons why there's all this depolarization, and that's why you get these fasciculations. So it's always helpful for me to understand the sign. So yeah. And then, as I've said, I was trying to get as many demonstrations of these actual signs. So you can see that this is happening in multiple muscle groups. So rather than just a sort of physiological, I used to get it in my shoulder or my eye, and it was only ever there. Whereas that gentleman's got it all over his hand. So yeah, that's much more indicative of, disease. And you can also get it in the tongue. I always find it hard to know, but I guess if you're asking the patient to stay still, then this would be very abnormal. But yeah, so that's a tongue fasciculation as well, just to give you guys an idea. So then we're going on to the special tests. And the first one we're doing is the slow release and grip. So the idea with this is that you're going to ask the patient to make a fist. And then when you do that, you're then going to ask, or you do it on both hands, I guess. And then you'll ask the patient to, when you tell them, to quickly release their fist. So as you can see, I can do that very quickly. In a patient who can't do that, they will have maybe a slow release and grip. And that may be a bit more like this. and it takes a very long time for them to open their hands. That is a very pathognomonic sign of myotonic dystrophy. And so breaking that down, myotonia is the prolonged contraction of muscles because they're harder to relax. And this is because in myotonic dystrophy, you have issues with the chloride channels in particular, and that leads to issues again with polarization and depolarization. And so that's why you get that sign of the slow releasing grip. And I just wanted to give you guys a demonstration of that as well. Because some of these things I've never seen myself, but it's always useful to just try and consolidate that knowledge. And as you can see, you know, I can do that very quickly. That patient gets a little bit and then it's much slower. So that's your slow releasing grip. The next special test, which I think is probably just actually a test that we do normally, not necessarily specific to PACES, but this is, they should have been the other way around, but this is very useful test when you're looking for signs of upper or lower motor neuron disease. So this is an upper motor neuron sign. This is pronator drift. And this is very, very common in upper motor neuron pathology. Basically, you're going to ask your patients to put their hands out like this, and then you're going to ask them to close their eyes. And if they have a upper motor neuron pathology, then they will start to drift their arms from pronation and back to supination. Okay? Oh, that's the other way around, isn't it? That's supinated. So they're going to pronate, and that's why it's called pronator drift, yeah. The idea with this is that this is all from pyramidal weakness, or pyramidal weakness. I can never say that word. And that is the pattern of weakness that you classically get in upper motor neuron pathology. So this is because the corticospinal tract, which is your voluntary movements, you've basically got spasticity. And so when you have this pattern of weakness, typically you have flexes in the upper limbs that are stronger than your extensors. So that means that in general, so for spinal cord injury patients, they will have a bilateral flex position like this, and they'll have their wrist flexed, their elbows flexed, and that's because their extensors, so their wrist extensors and their elbow extensors, their triceps, are weaker than their biceps. Okay, so you end up in the flex position like this. And so actually, this is in the example of the stroke patient. That's how they would look. And then you get lower limb, you get an extended pattern of weakness. And this is really important when they're thinking about a spastic gait, which often people say, and they don't necessarily know exactly what it means. It means that the lower limb is in that extended position. And so often, if you look at their shoes, it will be their front of their shoes will be taking the most wear. The sort of their big toe region will be taking the most wear because they're extending all of their lower limb, and that's really where the contact with the floor happens. So this gentleman is going to feature quite a lot. He has some very good content on YouTube, I have to say, and I'm gonna I don't have all the references just yet, but I will get all of these references, and I'll put them in the comments of the talk, so you can go and find these, or maybe you can click on them and test yourself.
That's what we're going to have you do is just hold your hands right out in front of you, palms up, hold them still, close your eyes. You look for any type of drifting or pronation, and there's none. If you were to have a pronator drift, which would be an abnormal response, it would look something like that. She has no evidence for that. Very good.
So that's how you test for it. And then I think this is a gentleman from memory.
Up, and then you just hold it there as long as you can. Close your eyes now. Close your eyes. You just hold that there.
You can see even early on, it's very difficult to actually get that palm flat.
As long as you can. As long as you can. You hold that there. Hold it as long as you can. 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 You just hold it there as long as you can.
And you can see that from the start,
And you just hold it.
that's really quite a significant change in position. So he's gone from slightly, pronated to, almost pretty much on the left. So that's definitely a very positive pronator drift. And the idea, just to consolidate why this happens and what you're thinking about, if you guys put your arm into a sort of flex position, say, like the diagram of the hemiparetic patient. So you have spasticity in the upper limb, you're going to be in a flex position, and then you go to the test position for the pronator drift, and then you go back, you realize that actually, of course, these patients drift like that because that is, that's the flex position. So this is exactly why we see this in upper motor neuron lesions. So I've not inserted a video there, but I've done it for you. So hopefully that consolidates your learning a bit. Now, in general, in the start of your neurology exam, and I am going to do a breakdown of the whole exam where I just go through what the special tests, and you'll watch me do the sort of the routine. It'll be normal, but on a volunteer. But in general, you're going to have the patient put their hands out stretched, and at that point, there may be some things that you start to notice. And the main thing I'm thinking about may be tremors. You may also get them to do these special tests. So we've done the pronator drift, we've done the slow releasing grip, and we're going to do one more. But I believe this gentleman may have a tremor, but let's see what his...
We are seeing a patient of postural tremors. I am asking the patient to outstretch the hand. We can see there is tremors in the both hands, right more than left. You can see again, when he is outstretching the hand, we can see the tremors, right more than left.
So yeah, so like I said, so putting the hands out stretched is going to be part of, going into the pronator drift. You're going to do that, but you're also going to do that for your looking for scapular winging, and that may demonstrate that there's actually a postural tremor. So that's an opportunity to inspect that. Obviously, you're going to hopefully see the patient before in the bed or the chair, and you're going to be at first going to be seeing, do they have any resting tremor? But these special tests are potentially a way of eliciting, if they don't have a resting tremor, demonstrating that they have a postural tremor. And we're just going to talk a little bit about the movement disorders, like I mentioned, just because I think it's like you're going to realize it at the start. Like I said, inspection is everything almost. So, so this guy obviously has a postural tremor. As I mentioned, you're going to be putting the patient's hands up like this. You're going to do your pronator drift, and then you're going to ask them to put their hands out like this, stopping traffic. And the idea, and you can hopefully see it in this patient, is that on their right-hand side, their scapula is quite winged. And this is a special test for facioscapulohumeral muscular dystrophy, which is a type of muscular dystrophy and is pretty rare, but I would recommend doing that right at the start and having a look at their back. You may want to have a look at their neck as well to see if they've had any surgeries. Potentially have had a cervical myopathy or a decompression surgery. So that's an opportunity to have a look there as well. But the main thing is that if you see scapular winging right at the start, then that's really helpful. And then you can have a look to see if there's any fasciculations. Do they have wasting of the face? Do they have any fasciculations in the upper limbs? And all of a sudden, exactly what the diagnosis is right early on. And then it's not necessarily about anything else other than demonstrating that this patient has facioscapulohumeral muscular dystrophy. So yeah, we're coming to the end of all the really weird special tests, just to reassure you. And now we're coming on to the movement things. So I think it's in the description here. So this is pseudo-athetosis. And what I want you guys to appreciate is that halfway through the video at this point, he starts to close his eyes. I don't think it's that obvious, but the idea with pseudo-athetosis is that essentially it's pseudo-athetosis. So rather than a pure athetosis, which is a movement disorder where you have very fine movements of the fingers, and that is, they call it piano playing. His is obviously unilateral. But you would think about athetosis in a patient that has is basically basal ganglia kind of bleed or lesion. You may get a unilateral athetosis. The idea of pseudoathetosis is that actually it looks like athetosis, but it's caused by sensory ataxia. So the patient actually has a sensory issue. They don't have good proprioception. And so this is normally worse with their eyes closed and actually okay when they have their eyes open. Obviously, I don't think is that much worse. Obviously, I'm getting these things from YouTube, but that's an important thing to just be aware of. And the reason we're talking about it right now is that you walk into the neuro station and the patient, get them to put their hands out and they start playing the piano. You guys hopefully now have an idea that this is either athetosis or pseudoathetosis. And the idea is that, these are fine movements, maybe bilateral, maybe unilateral. It's often described as piano playing. And like I've said, pseudoathetosis should be much worse when they have their eyes closed, and that's because it's caused by sensory ataxia. And I do have like a summary of all these signs in the presentation, so you don't need to necessarily take notes down, but and I'll get those tables out to you guys as well, so they'll be available. But yes, I appreciate it wasn't a great example maybe, but pseudoathetosis. And the other thing to talk about is Romberg sign. So we're going to talk about that a bit later, but that is another sign of sensory ataxia rather than a central ataxia. So those patients, they don't have good proprioception, so they don't know where their joints are. It's a sensory issue, a peripheral sensory issue, and that's presenting like ataxia. So Romberg sign, that's what we use to differentiate between central ataxia, so a problem with the cerebellum, and a sensory ataxia. So that comes a bit later on. But these patients who had pseudoathetosis, they will have a positive Romberg sign. Whereas if you have athetosis, you shouldn't have a positive Romberg sign, okay? Because that would be a more central ataxic syndrome, okay? Hopefully I've explained that. But all I want is for you guys, if you happen to walk into the exam and the guy's playing a piano as you put your hands out, hopefully you have an idea of what to think about and you can go away and read it up and things like that. So yeah, like I said, this is hopefully a map of things that you guys just need to be aware of. And we are going to focus on the main things that come up. This is definitely on the fringes. So the idea is, again, to just touch on these. So chorea, when and we have a few examples of this, but I have seen a patient with chorea, and it's much more, rather than athetosis, which is just normally on the fingers, and I've seen that as well. Chorea is much more violent, is much more of like a whole limb thing. It's usually the upper limbs, and they are flowing, but they are also quite jerky sometimes. And the patient literally cannot not do it. You walk in and you're like, why is the patient moving? And then you realize, oh no, the patient is trying to stay still. And yeah, so that's chorea. Athetosis, we've kind of touched upon. These are much more finer, slower movements, normally of the fingers. And then you have pseudoathetosis. And as I said, the distinction is when the eyes are closed, this should be worse, and you'll have a positive Romberg sign. And then the other things that these aren't necessarily abnormal involuntary, well, they are abnormal involuntary movements, but they're not necessarily like as dramatic as those. And maybe you have a better idea of what to do with a tremor. But then you have your tremors. So you can have your resting tremors. These are your classic Parkinson's, where you walk in and their hand is just moving, sort of 4 hertz, pill rolling. It's normally unilateral, it can be bilateral, normally worse on one side, and then you distract them and these get worse. This can be positional. So when you get them to put their hands out, like that gentleman, he had a bilateral tremor worse on the right-hand side. And then there's also intentional tremor. So this is what we're going to see in our finger nose testing. That is very classical of things like ataxia. And obviously, depending on what type of tremor you have a different list as well. And we are actually going to touch on that. I don't really know why I put that list in, but I have, and the other lists will come. But it just gives you an idea of, when I first started PACES, I didn't know how to assess a tremor, and we're just going to touch on that now. So this is our example of chorea. So you can see there's actually some trunk involvement, maybe some neck. His eyes are moving as well. And there's a lot of sort of these circular movements. It's very classical of chorea. So it's multiple muscle groups that are affected. And then this is an example of hemichorea, so unilateral chorea. So you can see much more significant than the guy who had pseudoathetosis, involving both the arm and the leg. So yeah, very difficult. And I think chorea in general resolves in sleep. So that's another thing that's useful as a sort of, you know, say, God forbid you get this in your consultation session. I don't think you will, but yeah, that's a classical history, is that chorea gets better with sleep. So it stops when they're sleeping. Here we have athetosis. And as you can see,
involuntary, random, asynchronous piano playing movements affect the fingers of both hands.
As you can see, that's much more subtle than the chorea. So it's mainly just the fingers. And they're much sort of slower, low energy. So that's your athetosis. And her eyes were open. And then we're coming on to the idea of inspecting the tremor. So obviously, when you first walk in, you're going to have the patient at rest. And that's when you're going to pick up a resting tremor. So that you, like I said, and I will keep bringing this up, the idea that so many of your signs are going to come from just walking in and inspecting the patient well. That's what's going to put you on with a resting tremor, and then put you down the idea of maybe I need to examine this patient for Parkinson's. And that's a separate sort of neurological exam that we're not going to cover in this. But, you know, if you see that the patient has predominantly resting tremor and maybe isn't very expressive in their face, then that's probably something you want to think about testing for their bradykinesia. You're going to test their tone anyway. But yeah, so the key thing with inspecting that tremor at rest is whether it gets worse with distraction. So you may get them to tap on their opposite leg, and that may make their tremor worse. Or you may get them to count backwards from 10, and that sort of concentration that's required to count backwards, maybe you do it with like count backwards by sevens from 100 or something difficult, that will make it much worse as well. Obviously, I've said that when you're inspecting the tremor, you start at rest, and then you're going to put their hands out anyway. What you can do is put some paper on top of that to demonstrate if there is a very fine tremor. And in general, people seem to put their hands out like this and then put their hands out like this. I don't really know what difference that makes, but perhaps tremors are more pronounced in different positions. I don't know. I'm not a neurologist, but that is essentially what we were taught to do. So you want to have your hands out like this, and you're going to be properly looking, demonstrating that you're looking. And then obviously you're going to come on to your finger nose testing. That's where you're going to see your intentional tremor. So intentional tremor will start, but get more amplitude as they're getting closer to the target. So if that's your finger, for example, if the camera is my finger, the amplitude is going to get worse. And then as I come back to my nose, it will get worse. Yeah, so that's your intentional tremor. As you get closer to the target, the amplitude gets worse. And then obviously, as part of your upper limb, you're going to be doing a functional assessment. But that's really important when it comes to things like tremors. You know, these patients really struggle with buttons or drinking from a cup. You know, intentional tremor is going to be awful for that. So again, that's more to just demonstrate. You're not going to do a full functional assessment, but you can say, I tested and the patient was unable to do up a button. I would want to do a full functional assessment. That's the kind of reason. So I've put down your differentials for this. Essentially, postural tremor, there's actually quite a lot of causes which aren't really neurological. So, you know, drugs, caffeine, drugs, alcohol, thyroid. Your intention tremor is obviously your cerebellar disease, your ataxias, and then your resting tremors are more your Parkinson's and your Parkinson plus, which is another list that you guys will, you know, be very good at, and then your essential tremor as well. So I just wanted to do this, and then we can say that we've addressed this. But I appreciate inspection is quite long, and it's going to be The others are a bit slower. This is your classic Parkinsonian pill rolling is the idea. And it's normally unilateral. Normally unilateral is normally about 4 hertz. And that's your classic Parkinson's thing. If you got the guy to tap with his left hand on his knee, then that would probably get worse. And then you'd find other features of Parkinson's. So rigidity, maybe cogwheeling as you're assessing his tone and things like that. And then one of the things that's quite typical of Parkinson's is what we call a re-emergent tremor. So this is going from a resting position to a positional position. And then as time goes on, the patient will have a re-emergence of their tremor. So almost at the start, they're in a positional, but then almost their body starts to you know, as time goes on, it gets more pronounced. So we'll just have a look at that. So this is a resting tremor. Again, quite similar to the last patient, unilateral, quite typical of Parkinson's. And then she moves her hand, and initially it looks a lot steadier. But as you can see, as time goes on, it becomes more and more pronounced. And that's what we call a re-emergence of the tremor. So really quite profound. You know, now you barely know, and then it just gets worse and worse. So very interesting. So, like I said, this is your summary of those signs. I've highlighted the top ones because these are essentially the key ones that we're thinking about when we're thinking about that question of, is it upper or lower? Obviously, I appreciate some of this is fairly basic, but we are going to build on this. And we have just gone through all of those special tests. And I think these are everything you need to know for Parkinson, for PACES from a special test point of view for neurology. So that in itself, you know, the upper limb in particular is quite useful. So I will not read that out. You guys can have a look, and I will make that available as like a downloadable thing in the comments or whatever. So that will be available in the next couple of days. So we've done inspection. So well done. Next is obviously tone. And again, we're asking that first question, is this upper or lower motor neuron disease? This is slightly easier. Hypotonia is obviously upper motor neuron disease, and hypotonia is generally lower motor neuron disease. You can have normal tone, obviously, on exam. And there is, as with everything and every single one of these things, there are some nuances. So hypertonia can be made up of spasticity or rigidity. And the important difference between spasticity and rigidity is that spasticity is what we call velocity dependent, whereas rigidity is consistent throughout the assessment. So most of your patients that have increased tone will have spasticity. This is your upper motor neuron classic signs after a stroke, after MS. That, you know, you hear about these patients, they have spasticity management. Your Parkinson's patients are your ones that have rigidity. And this is the idea that they have lead pipe rigidity. So when you're assessing a patient for their spasticity, one of the things we often do is have a look at their pronation. And what you may find is that they have a catch. So you start the movement and you can do it. And then as you're sort of increasing your speed throughout the movement, then it catches and it's much slower and harder. And you'll see that as you jerk their, as you move their limbs quickly, almost you get more resistance. Rigidity is not the case. So you'll be asking a Parkinson's patient to relax and they will just be totally rigid. And that's throughout the whole movement. Hypotonia is obviously a lower motor neuron sign, but it's also a sign of cerebellar disease. I would argue that it's harder to say someone has hypotonia than it is to say hypertonia. So I'd caution dishing out the, you know, hypotonia unless you're very convinced of it. It is obviously pronounced in lower motor neuron disease, but yeah, I wouldn't say that's your like best sign. For example, for cerebellar disease, I would say, you know, the fact that ataxic is far more safe and also, you know, reproducible. So I just would not, you know, just a word of caution with dishing out that, oh, I've seen hypotonia. It may be slightly subjective. And then the other thing to mention is that obviously in acute spinal cord injuries, you will have hypotonia. Although it's an upper motor neuron lesion, you will get hypotonia initially. And also some, upper motor neuron lesions will take a bit of time to develop their tone. So there's just those nuances. I imagine that if a patient is in PACES, they're going to have had their injury for some time. And so they're going to have tone. They're going to have high tone if it's an upper motor neuron lesion. But it's just, again, to be aware of and to be able to caveat. So yes, hopefully that is all clear. When we're coming to assessing tone, so this is one of the things that actually I see quite a lot in PACES teaching, is that candidates have, they have a bit of a routine, but I think almost going back to the basics is really helpful. So I work day to day in neuro rehab, so we do a lot of spasticity management. And essentially, when you're assessing someone's tone, you're trying to move the joint through the range of motion. So if I was assessing the tone of the wrist, we're going to be doing wrist extension and wrist flexion, and they may have, they typically have much more flexor tone than extensor tone because of the pattern of pyramidal weakness. So often we will Botox the flexors. But if you think about your assessment of tone and basically just do that, so it's going to be flexion and extension of the wrist, pronation, supination, and then same at the elbow, flexion, extension, and then also having a feel of the shoulder. That is essentially all you're doing. Some people kind of, they do like a compound movement almost, and it's like, essentially you just want to assess the joint through a range of motion. I'm going to do hip, I'm going to do wrist extension and flexion separate to supination and pronation. I wouldn't do it all at once, basically, is what I'm trying to say. And I guess I just wanted to make the point that obviously, as much as this in our PACES is going to be diagnostic, we're trying to assess, is it high or low tone? In actual real world, tone assessment is going to be part of your therapy as well. So, for example, when I'm on the rehab ward, we may do many tone assessments, go back and see the patient many times before we make a decision to do Botox and which muscles to do that in. And that's the whole thing of spasticity management, which is a very complex thing in itself. But I just wanted to, make you think about that when you're doing your tone assessment. Just keep it basic, go to what is the range of motion of that joint, and then move the joint through that range of motion and assess, is it high tone or low tone or normal tone? Yeah, that's as simple as it is. So, like I said, when it comes to tone, we're answering the question of where is the lesion, as in, is it upper or lower motor neuron? I've mentioned that, we've touched on these things. So why do you actually get high tone? So again, I quite like to understand why we have these signs because it helps me remember it. But tone is the resistance of muscles to a passive stretch. That makes sense, doesn't it? When we're moving the wrist through extension and flexion, we're asking them to relax. So it's a passive stretch. And if you have high tone, there is increased resistance. Basically, why that is happening is because if you have a lesion of your upper motor neuron, you basically lose the inhibitory signals that come usually from a working upper motor neuron. So the upper motor neuron would normally be putting the brake on your spinal reflexes and your tone. However, as soon as you have a damage to that upper motor neuron, you lose that brake, and so you get increased tone, and you also get increased spinal reflexes, which is also, why hyperreflexia and tone are quite similar. If you have high tone, you're very likely to have hyperreflexia, and so that's what you'll find. So yes, that is essentially why you end up getting spasticity. And we've talked a bit about spasticity versus rigidity, but obviously it's velocity dependent. The way that I think about it is, I don't know if you guys have ever used corn flour, and if you put corn flour in a load of water, essentially if you hit it really quickly, the corn flour puts up loads of resistance. Whereas actually if you put your hand through the corn flour very slowly, it just absorbs it. And it's this kind of similar, it's not entirely the same, but it's quite a similar process to spasticity. So it's almost velocity dependent. So if I hit corn flour, I make a bowl of corn flour, pour a load of water in it, it's nice and liquid, and then I go to hit it, it will hurt my hand. It won't let my hand enter the corn flour. But if I just slowly push my fingers through, it will act like a liquid. And I use that as like a way to think about spasticity. Rigidity is obviously cogwheeling. So that's the That's the cue that I've used here. And actually, again, breaking down what is cogwheeling. Cogwheeling is the fact that you have a tremor on top of rigidity. So this is very classic Parkinson's. Not only do you have rigidity, you have a tremor. And so how it feels is that you have this stiff arm and then a tremor on top. And so you can imagine that actually it feels jerky, like it's going through a cogwheel. But that's actually the tremor that is superimposed on the rigidity. So yeah, just to be aware of. Clonus. This potentially could be in tone. I imagine you could argue it could be in reflexes. But essentially, clonus is going to be seen. You can actually get it in your wrist and other places, but we typically look for it in the ankle. And what we're doing is stretching the muscle very quickly. It's normal to have some clonus. So if you test clonus in lots of patients, they'll have a couple of beats of clonus. But sustained clonus is abnormal. And we'd call that non-fatiguing clonus in the most severe end of it. But sustained clonus may be 10 beats. Non-fatiguing would be, it will carry on until you deload the stretch of the muscle. This is very indicative of high tone. Is therefore a motor neuron, upper motor neuron sign. And it's, again, a spinal reflex that's triggered by a muscle stretch. And there's lack of the brake on that spinal reflex, which is why you get it. So this is our example of clonus. So it's a rapid stretch, and then we've gone very, way over 6 beats, haven't we? And actually, it doesn't self-fatigue. It's not, terminating itself. And we'll see if it does, but I think this is probably non-fatiguing clonus. And I've said there which muscles are responsible for this clonus. So because the knee is flexed, so the knee is not straight, that means that this is coming primarily in this test from the soleus. But obviously that patient may also have clonus or spasticity in the gastrocnemius. But to assess the gastrocnemius, you would have it as the knee is extended. That is beyond the scope of PACES. That's just something that we talk about in Botox and spasticity management, which is obviously what I do. Hypotonia, as I've said, is arguably a difficult sign to pick up. So I wouldn't bet the house on a patient being hypotonic. But in the absence of high tone, you can obviously consider hypotonia, especially if they have lower motor neuron pathology. But like I said, I would probably stay away from it in cerebellar disease because there's just better signs. And then the way you're going to assess this, especially in the lower limbs, is by rolling the leg on the bed. And what you want to be doing is looking at the ankle. What's the ankle doing? Is it just flopping around, which is what you should be able to see in hypotonia? I would argue that it's much easier to assess the hypotonic lower limb than the upper limb. But that would just be, within the constraints of a typical neuro exam. I'm sure there are many ways to actually assess it, but that's beyond the scope of PACES. There weren't many good videos on YouTube. Let's just have a look at this one.
Syndrome, which is a lower motor diagnosis. Here we demonstrate hypotonia.
I mean,
I'm not feeling a little bit of resistance. You can see.
It does seem very floppy, but I wouldn't do this in your exam. So, but yeah, there you go, hypotonia. And that is essentially your updated main signs when we're thinking about the first question. So is this upper or lower motor neuron? We've got our inspection sort of main signs in there. We've taken out the special tests, and now we'll just put the tone ones in, and we're going to obviously populate this table as we go through the talk. So power is the next big one, and then hopefully it wraps up a bit quicker at the end. But yeah, this is a bit of a longer talk. So as I've mentioned, you should have a hunch at this point when you're assessing power as to whether they have an upper or lower motor neuron lesion. And actually, power is not really going to help you. You're going to have low power in a lower motor neuron lesion, say a median nerve, carpal tunnel. You would have low power in that lesion, just like you'll have low power in a spinal cord lesion. So it doesn't differentiate between the CNS and the PNS. But we are going to use power to demonstrate where exactly in the due to the pattern, we're going to use it to demonstrate where exactly it is in the CNS or the PNS. So our CNS is made up of our brain, obviously, and then our spinal cord. And then as we come down at the spinal cord, our first synapse is going to be within the anterior horn. So you have your anterior horn disease, and that would be your first point at which you could get lower motor neuron signs. Then you have your spinal root, your plexus. Your plexus is really complex, and actually we're going to sort of touch on these issues, but we're going to stick to the main sort of, again, this is a bit more of a map. So we're going to go from our spinal root, then to our plexus, then to our individual nerves. So things like the median nerve, for example. And then obviously at the synapse there, you have the neuromuscular junction. So you have your conditions that affect that. So myasthenia gravis in particular. And then you have your muscle itself. And that's to remember about your myopathies. These are in your differentials, and there are ways to assess whether it's a nerve, a peripheral neuropathy, or your myopathies. And we're going to talk about that as well. The pattern of the weakness is essentially what I want you to think about, because that is going to give you all the clues as to where in the CNS or the PNS that is actually happening. Okay. And the idea is that these are like two trains. So if I'm going back to Nottingham, I may have to get a train to Loughborough and then change. And depending on, say, there is disruption, depending on where that travel disruption is, I will get a different pattern, or there'll be different number of people from different places affected, depending on if the train breaks down in Leicester, or if the train is stuck outside of Loughborough Junction, stuck outside of Loughborough on the first train. And the first train is obviously representing our upper motor neuron, and the second train is representing our lower motor neuron. So if the train gets all the way to Beeston but breaks down there, that may be the same as having a common peroneal nerve injury. Whereas if it's on the second train but it never leaves Loughborough, that may be anterior horn. And this is the kind of idea that I was trying to get at with this kind of metaphor is the word. So the idea that there are true trains, that's your upper and your lower motor neuron. They synapse at Loughborough, and if you have an issue, for example, in the first train at Loughborough, then you're going to have a bilateral paraparesis, indicating a spinal cord injury. Whereas if you have an issue at Beeston, you're going to have potentially a foot drop. Or at Nottingham, you're going to have a myopathy. It doesn't quite work perfectly because of the myopathy issue. But anyway, there you go. That's my metaphor for the day. So let's just test our knowledge a bit. We're going to have a think about the power in this case. This gentleman, for example, has got normal muscle bulk. They have a positive pronator drift, and they have spasticity. So from that, we're thinking that this is probably an upper motor neuron lesion, but we don't know where the lesion is. And that's because I haven't told you whether the pronator drift is unilateral or bilateral, or whether the spasticity is unilateral or bilateral. That's the question that you should be asking yourself. And this is the point that I'm trying to make, is that actually when it comes to muscle, when it comes to power, we need to be thinking about the pattern of the weakness, which is going to tell us the next thing as to where this lesion is. So is it unilateral, left limb, left arm and left leg, or is it bilateral, both lower limbs, for example? So if it's unilateral, then all of a sudden we're thinking about a hemiparesis. And so this would indicate a lesion within the brain. I appreciate that this is maybe very basic for some of you guys, but I think just to go through it, you will then benefit from the map at the end as we sort of go through every single, CNS, brain, spinal cord, and then into the PNS. And the PNS, in my opinion, is much, much harder. So yes, we're building up to that. Obviously, with hemiparesis, we have a lesion, for example, in this case, this gentleman had it in his left, I think it was left weakness. Yeah. So that is going to demonstrate a right-sided lesion because obviously you get decussation. And so the right side in general will lead to power in the left side of the body. So that's the point with hemiparesis to remember. We have essentially answered those two questions. He had upper motor neuron signs, so we were thinking about the CNS, and then because it was the hemiparetic pattern, we were then thinking this is probably in the brain. There is a caveat with that, and I will not apologize for these caveats because this is neurology, unfortunately, but ipsilateral facial signs will also be present in the case if the lesion within the brain is within the brainstem. And this is to do with the fact that the cranial nerve cell bodies are at the level of like the pons. So essentially you get a lower motor neuron lesion on the ipsilateral side of the face if the lesion is within the brainstem. I wouldn't think about that too much more. There are these specific issues, and we call these cross signs, and you get all these syndromes. I'm just thinking about the time. I'm probably going to just skip over this. But these are where you get your things like lateral medullary syndrome, which is a classic one. And yeah, I would have a look at this. Again, this is just to maybe just give you a heads up as to, these things exist. But in general, I don't think this is to spend too much time on. In general, the point is hemiplegia, you're thinking of brain and you're thinking the other side, but there is also these ipsilateral face syndromes, and you can have a look at that. They may come up. I think it's probably a good idea to have a look at them, but we'll just, I'll signpost you to them in this talk. So we have talked about hemiparesis. We are now going to talk about paraparesis. And this is obviously when you would be thinking about paraparesis. So if we take the same patient, they have normal muscle bulk, doesn't quite work with pronator drift. So forget about pronator drift, but they have normal muscle bulk and they have spasticity, and then they have power loss bilaterally in both their lower limbs, then you're going to be thinking about paraparesis, aren't you? And this would indicate a spinal cord injury. The reason you know it's spinal cord is that it has upper motor neuron signs. So if a patient presented with this type of weakness, but it was lower motor neuron signs and it wasn't an acute injury, then you may be thinking about something else. And that would be bilateral anterior horn, and that would be things like SMA. But we're going to touch on that later. But the fact that you have upper motor neuron signs tells you this is in the spinal cord. And that's why you have to answer that first question first, because otherwise you get to the pattern and there are different patterns depending on if they have, upper or lower motor neuron signs. So we ask that first question and then we come on to the pattern. Obviously, paraparesis, you would have an injury of the spinal cord, and that would, depending on the level of the injury, give you different patterns of weakness. So I've again indulged in the metaphor of the lesion being either at Leicester or Loughborough. So if it was Leicester, then you'd be thinking about a cervical injury, and that would be involving both arms as well as both legs. Whereas if it's just at Loughborough, then you'd be thinking more about a thoracic injury, and that would be affecting including the lumbar region. So that would be your legs would be weak and spastic, but your arms would be fine. And so these are your wheelchair users in rehab typically. Every single time, though, they have a spinal cord injury, they're going to have bladder and bowel involvement. And this is quite often forgotten. But, just in your Viva, management of bladder and bowel in all of these neuro patients really is important. And that would be part of your MDT approach for your Viva answer. So we have gone over your hemiparesis and your paraparesis. These both are going to have upper motor neuron patterns. That's your first question answered. And then depending on the pattern of weakness, you're going to be able to figure out, is it a brain or spinal cord injury? That's fairly basic. I've mentioned that I like to keep it simple. So I just like this idea that the nerves that supply the arms, the nerves that supply the legs, it actually took me quite a while to figure that out. But when it comes to neurogenic bladder and bowel, which I've talked about, the other thing that I struggled with was remembering what that actually meant. But this means constipation and retention. And if you think about the paralysis of these muscles, just like the paralysis of other muscles, then you're going to be onto the right thing. If you paralyze your bowel, it's not going to poo as well. And if you paralyze your bladder, it's not going to wee as well. And essentially that is it. Okay. And we do quite a lot of that management in rehab. So yes, the idea that in a sensory exam, the last level of normal sensation is normally indicative of where the lesion is. So then you'd have a look at your T10 being your umbilicus, your T2 being your armpits. That we call it an Asia chart for spinal cord injury. That can be useful as well. Again, I don't think you're probably going to have time to do that within your sensory exam. I'd be very impressed if you did, but that's just to be aware of. These patients will often complain of having like a weird belt-like sensation at the level of their injury, and that's very common. So now we come on to the PNS. And so obviously I've put my metaphor up in the right corner, but we are particularly talking about the anterior horn. We're then talking about the root. Then we're talking about plexuses and then individual nerves, the neuromuscular junction, and then the actual muscle itself. And what we're going to do is talk about the anterior horn. We're then going to talk about the nerve roots and plexuses, and probably peripheral nerves. I mean, you guys probably know your peripheral nerves actually, but I'm going to really just touch on roots and plexuses because I really think it's probably beyond the scope of PACES, but it's just to get you to think that actually if the examiner is asking you more and more, you've said it's a peripheral nerve, and they're still asking you what else could it be, then you can always go back and say, well, actually, I thought this is probably the ulna, but it may also be higher up in the plexus, or it may be, a spinal root injury as well. But obviously, I think it's going to be really harsh if they expect you to be able to differentiate that. That's just my opinion. But that's not verbatim. But we're just going to touch on that because it's a lot of learning for not very much, like diagnostic gain. And then I've talked about the neuromuscular junction and muscle. I actually don't think we're going to cover that all that much. We're mainly just going to cover the muscle. But yes, that's how we're going to think about it. Obviously, these patients are going to have lower motor neuron signs. So that is our first question. We've answered that. They have muscle wasting, they have fasciculations, they have hypotonia. Then we're thinking about the PNS. Realistically, like I've said in the last minute, we have to put our eggs in the correct baskets. So obviously 25%, so peripheral neuropathy and Charcot-Marie-Tooth make up 25% of your lower motor neuron cases. So I wouldn't worry too much about your foot drops or your median nerve or your on the nerve palsies. They may come up. I really wouldn't worry about plexopathies, but it's just to be aware of them so that you can say, oh, well, it could be this, but also I'd think about this. So I would highly recommend having a look at the Clinical Skills Pro article, which is what will come up in my PACES exam. I still use it fairly verbatimly. It is quite old, but I don't think PACES changes all that much. So yes, this is a useful tool and something you should consult, not just in neuro, but in everything when you think about PACES. And so essentially, this is what we're going to try and talk about, is this different pattern. You can see plexopathy and radiculopathy there. I wouldn't worry too much about that. The main things we're going to be talking about are, is it a mononeuropathy? Is it multiple mononeuropathies? Or is it a polyneuropathy? And there is a slight caveat with polyneuropathy as well, because some polyneuropathies, I'm talking about things like CIDP, so chronic inflammatory demyelinating polyneuropathy, as well as GBS, they actually are not length dependent. And this is a term that you'll see in your nerve conduction studies. But the polyneuropathy there, that is very much a length-dependent polyneuropathy. So the longest nerves are affected first. This is something you see typically in things like diabetes. So a glove and stocking distribution, that is a length-dependent polyneuropathy. However, with things like CIDP, when I've seen CIDP patients at work, they have very weak proximal, so it's their shoulders and their hips that are affected most. And so actually, although it's a peripheral neuropathy, it's not length dependent. And so actually your myopathy, that kind of pattern of weakness, is much more of a differential for things like CIDP rather than this kind of glove and stocking pattern of weakness. So that's just, again, another caveat that neurology loves to throw in. But this is how I want you to be thinking. We're essentially trying to map this map onto this weakness, and that's what we're going to talk about. So the first pattern would be anterior horn cells, and this is not very common. It is more common in PACES, essentially with post-polio syndromes. So you normally have a patient with a limb that is withered, and essentially they have a low tone, very small limb compared to the others. And that is like typical of post-polio. And the idea is that the anterior horn cells, they're the very first part of after the synapse in the spinal cord. And so it affects the whole limb in general. If you have that unilaterally, you're thinking about polio. If you have it bilaterally, so a hypotonic paraparesis, So most of our paraparesis is going to be spastic paraparesis, hypotonia in a bilateral lower limb pattern. However, in a hypotonic, so bilateral pattern of weakness like this, you are thinking about spinal muscular atrophy, which is an inherited disorder. There's many different types. Actually, some of the types, they don't make it past like childhood, but one of the types has this pattern of weakness, and that's because the anterior horn cells bilaterally are being affected. And so those are your two patterns of weakness to think about. Obviously, these patients are going to have those lower motor neuron signs. Just to briefly touch on the anterior horn, I've kind of just said it, I hope. But the upper motor neuron and the lower motor neuron, they synapse within the ventral horn, and then they immediately go to the anterior horn. Okay, so this is like the first point after the synapse. So it's the most proximal part of the lower motor neuron. And so, you know, thinking about the train idea, so it's the second train is not leaving Loughborough, so it's a lower motor neuron issue, but the maximal amount of people are being affected by that disruption. So that's how I think about it, with the whole limb being affected, because it's so proximal, but it's still in the lower motor neuron. So you're going to have those lower motor neuron signs. And then M&D does actually affect the anterior horn. And so these patients, I think, if I'm correct, they will typically have their signs all happening in one limb at a time. And I believe that's probably because this is happening within the anterior horn. So again, it all kind of, obviously it does move around and they get other signs, and it's a very progressive condition. But they may start with, for example, a weaker arm or fasciculations throughout one arm. And I believe that's why they get mixed signs, because it's happening in the spinal cord and they get some upper, but also some lower motor neuron issues. So yeah, just to think about that as well. Again, so plexopathies, radiculopathies, I think they are very hard. I think they are probably beyond the requirements of PACES. But what I want you to think about is that, you know, if a anterior horn lesion is going to affect the whole limb, a radiculopathy or plexopathy are basically going to affect part of a limb. So it's not going to affect a single nerve, but it's going to affect part of a limb. So there's going to be multiple muscle groups affected, and it's only going to affect one limb normally. So unless they have bilateral root disease, which you could do, you know, bilateral sciatica is not unheard of, then you know, you're thinking radiculopathy, plexopathy. And the idea that I will touch upon is the idea that actually you have your anterior horn, and then you have your sort of mononeuropathy, so your single myotome affected, and then anything in between, you want to just think about radiculopathy and plexopathy. I don't think you necessarily need to be saying this is an L4 radiculopathy. I think you just have to be able to say this is, you know, I'm thinking about this in my differential. So that's how I would approach this. Otherwise, you're just going to have way too much to do, in my opinion. So yes, so we have cervical radiculopathy. Again, you can learn this. I'm not saying you shouldn't, but it's just, I wouldn't spend too much on these things. And then you have your lumbar root radiculopathy as well. So yes, and I know that, for example, you know, in your foot drops, your common peroneal nerve versus your L5, that's a classic kind of neurology. Is it root or is it common peroneal nerve? So maybe have a look at that one if you're going to look at any of them. But again, I don't think, you know, realistically, you're going to have a neurology consult and then you're going to have nerve conduction studies. And as long as you say that, and these are in your differentials, I think you're fine. Then you have your plexopathies, which are even harder. Typically, this is in kids. You get an Erb's palsy from like a yanking of their arm. But yeah, like I said, just be aware. So now we're coming on to mononeuropathies. Again, we're going to whiz through this just because it's quite a lot of learning and not necessarily much diagnostic benefit. I want to focus on the map rather than anything else. But essentially, you've got your ulnar, median, and radial nerve in the upper limb, and then you've got your common peroneal nerve in the lower limb. That's affecting your foot drop. We are just going to touch on the upper limb, I believe. And the way to do that is rock, paper, scissors. So paper is finger extension, and that's going to be your radial nerve. Your scissors, you may not assess them like this. You're probably going to assess it like this in your upper limb exam. But your scissor action, that is your ulnar, and then your rock is your median. And so they won't be able to do a rock like this. They can't flex their fingers like this. I believe they get a hand of benediction. So they try and make a fist and they can't. It's only these two that make a fist. But I'm going to demonstrate that, hopefully. So yes, testing your paper, that's going to be testing your radial nerve. So you're going to be pushing, keeping them in extension against resistance. And then the gentleman on the left has a right-sided wrist drop that is indicating a radial nerve palsy. Your ulnar nerve, that's when you're assessing their abduction and adduction of their fingers. And so that's your scissors. And you can develop something called an ulnar claw with an ulnar nerve palsy. Typically, obviously, we all know that the ulnar, sensation-wise, affects the pinky and part of the ring finger. So that's your typical sensation findings. And this is where your myotomes and your dermatomes map on one another. So your part of your sensation exam, if you think they have a mononeuropathy, is to confirm, is this typical, of a ulnar palsy? So yes, but they will get an ulnar claw, and this is due to unopposed action of the ulnar part of the flexor digitorum profundus muscle. But be aware that a ulnar claw is very different to a hand of benediction, and I think they're quite similar in that it affects the last two, but actually the last two in hand of benediction are normal. So let's talk about that. So the median nerve is your rock, so the patient cannot flex their fingers. The way we're going to test the median nerve is by doing abduction of the thumb. So you're going to ask the patient to put their hands out like this when you're testing pronator drift, for example, but then you're going to ask them to put their hands up like this. And so then I'm going to say, keep your thumb there, and I'm going to come down onto their thumb like that. That is thumb abduction, and that is very sensitive to the median nerve. Carpal tunnel syndrome is obviously the most common cause of median nerve compression, or maybe it is just median nerve compression. Like I said, these patients cannot form a rock. And so when they try to form a rock, you will ask the patient, can you make a fist? And they will end up doing that. So they cannot do this. Okay. And that's why you get this hand of benediction. This is different to ulnar claw. As you can see, the hand of benediction is different to ulnar claw, which is like, yeah. Anyway, just to make you aware, again, hopefully these are just things to be aware of rather than things that go and, rote learn everything. So we're going to whiz through these examples.
Can you form a fist?
So this gentleman cannot form a fist. So this is the hand of benediction. And so that is median nerve. Okay.
Open and close your hand 3 times for me.
And obviously this is much more ulnar palsy. We've got an ulnar claw here. Yeah. So you can see it in the first one before she puts the orthotic on. That is your ulnar claw. Okay. And then I did try and make these work, but they didn't. So you can see it when he compares it to the other one. With this gentleman's left hand, he's able to make a paper, but on the right, it's very difficult. So that's his wrist drop. So that's a radial nerve palsy. I think you can get them from like regional anesthetics, but I don't know enough. And then this is your classic scissors. So this patient isn't able to do the scissor action of all their fingers. So your finger adduction of the little finger in this patient is impaired. So that's an ulnar palsy. Okay. So mononeuropathy multiplex. Again, this is difficult, and I think it's rare, to be honest. But it's just something to be aware of because it does have a separate list that we would insert into our presentation. From the top of my head, diabetic myo something causes it. So you can get this in diabetes, where essentially you have bilateral foot drop, and you don't know why. But it's essentially the idea to get across in this talk is that you have mononeuropathies happening in multiple places. And it's usually asymmetrical. So that's, yeah, again, this is hard. It's probably beyond the, you don't need to know everything, but you just need to have a list so that if a patient comes in with mononeuropathy multiplex, you can say, well, this is the differential, which I can't quite remember at the moment, but diabetes is definitely one of them. And then we have polyneuropathy, which is your peripheral neuropathy. This is very, very high yield, and we will go through the list. And you have a different list depending on whether it's a sensory motor, or a motor peripheral neuropathy or polyneuropathy. And I just have already introduced the idea that you get length dependent, which is glove and stocking distribution. So the longest nerves are affected first. That is what we're seeing here in the example. However, that is not the only polyneuropathies that you can get. And I've said CIDP is a very good example of proximal symmetrical weakness. And so that would be actually a differential for things like myopathies. So your inclusion body myopathies, the gentleman who had quadricep wasting in the first one, that could reasonably be a CIDP patient. They could present like that. And the thing that we do is have a look at their reflexes. If they didn't have reflexes, we'd be thinking about a peripheral neuropathy, whereas if they had reflexes, but they may be smaller because the muscle bulk is smaller, but if they have reflexes, then you're thinking about a myopathy, and that's in our map at the end as well. Just a quick point. With the neuromuscular junction disorders, they have a normal reflex, normal tone, normal muscle bulk. The motor neurons are fine, the muscles are fine. It's an issue with the actual neuromuscular junction. So that's what you need to think about. Most of these patients are going to have ocular disease, so that's also useful. But the idea that it's fluctuant, you get fatigability, improvement with rest, these are all what you should be thinking about in your neuromuscular junction disorders. But yes, just to give you the heads up, they'll have a normal, majority of their exam is normal, and then they get fluctuant weakness. Then we have myopathies. So these are symmetrical. They are far more likely to be proximal. And reflexes are how we differentiate for these patients. So they will have muscle wasting. They will have fasciculations potentially. They may have low tone. But I think those are actually probably less likely because it's not an issue with the neurons. Maybe they have fasciculations. I don't know. But they definitely have muscle wasting. But they have reflexes. So that's the way that we do that. So I'm going to look into that actually about the fasciculations and things. But like I said, they have reflexes. So that's how we differentiate between these patients and a peripheral neuropathy patient. As I've said, there are many exceptions to the rule. But the thing with this is that actually you can use this as a get out of jail free card. So I've given an example here. The gentleman presents with proximal weakness and lower motor neuron signs. There are no sensory involvement, so I'd expect this to be a myopathy, which has a broad differential. Another differential would be peripheral neuropathy, E.G, CIDP. However, CIDP variants have a sensory component, but there are some pure motor forms, and reflexes were present, so that points me toward myopathy more than neuropathy. So I haven't really bet the house on myopathy there. But I've just demonstrated that actually I know what I'm talking about. I'm thinking about myopathy. I'm also thinking about peripheral neuropathy, and I have a list for both of them. If you want the list, I'll give it to you. And that's what you want in your exam. You basically want to demonstrate that you know what you're talking about. And the way to do that is to show them that you have that map of Loughborough and then East Midlands Parkway. Essentially, you want to have that peripheral neuropathy map going from the anterior horn all the way to the muscle. And you want to demonstrate that actually, if it doesn't quite fit, then you have to go back to that map and think, where else on this could it be in the case of lower motor neuron? It's obviously much easier in upper motor neuron, but that's what I want to get across, is that's what we're asking in power, is what is the answer to question 2? Where exactly is the lesion? So we know it's in the CNS, or we know it's in the lower motor neuron. Now, where exactly is it? That is what you're thinking about when you're assessing the patient's power. Obviously, you're going to have to do the MRC grade, and we can all do that. But that is the actual diagnostic question you're asking. Where is the lesion? Okay, so hopefully I've got that across. We have done power. We just have a few more, so bear with us. But now we're going on to reflexes. As I mentioned at the first slide, the idea that reflexes could potentially be put before power is the idea that actually they're asking or answering the question of question 1. Sorry, I'm just going to plug my camera in. See if I'm not sure that's going to work anymore. But anyway, sorry about this. Let's maybe just do that. Okay, my camera didn't like that, so just going to restart that. Sorry about this, guys. Okay, we're back. So we're at reflexes. So yeah, I made the argument that actually this is going to answer question 1 rather than help you. You started question 2 by the time you get to power, but essentially we're looking for more evidence of question 1. And realistically, in this, it's probably going to be is there hypotonia, basically, because hyperreflexia is essentially saying this patient has got high tone. The other important thing to talk about with reflexes is you have to practice your reflexes. You need to be able to say this patient doesn't have reflexes. And the way to do that is to be so good at reflexes that when you're testing this patient's reflexes and there's not a reflex, you're confident that it's not you, it's the patient. It's a sign. It's not, an examination error. And so that means that you have to be really confident and practice lots of reflexes. So that idea, I think, is really important. I think people, just practice your reflexes, essentially. And that is why. So you're going to be assessing, have they got hyporeflexia, hyperreflexia, or normal reflexes? You're also going to do Hoffman's sign, and you're going to do your plantar reflexes, looking for Babinski's sign. So we're going to go over that. Basically, your reflex arc, you've got a stimulus, then you have an afferent neuron. It's then going to synapse. It's one synapse in these reflex arcs that we're testing. And then you have an efferent neuron, and you're going to get a response. You can have a look at this. As we said, in upper motion neuron lesions, you don't have that break. And so you have increased tone and you have increased reflexes. Okay. Upper motion neuron lesions are obviously hyperreflexia. Hyporeflexia is lower motion neuron regions. And then I've also said that the idea that myopathy will have reflexes, whereas peripheral neuropathy won't. And reflexes are normal in neuromuscular junction pathology. And hyperreflexia is present in Parkinsonism because they have high tone. Okay, just because it's not spasticity doesn't mean it's not high tone. It's high tone. They have high reflexes. Okay, these are a brief summary of your signs for the reflexes. Is there anything we've not talked about? Just remembering that there are some nuances, and then when you're eliciting your reflexes, you want the muscle to be relaxed, and you also want the tendon to be stretched, but not too much. So basically, if I have a bicep that is completely flexed, I'm not going to get a reflex. Equally, if it's completely extended, I'm not going to get a reflex. You want there to be a bit of tension within the tendon. So you want that to be partly, halfway through the range of motion, and you want the actual muscle to be relaxed. So I find the best way is to have the patient sort of sat with their arms on a pillow out in front of them for the upper teeth, and then for the upper limb. And then you have to remember to use reinforcement. So either getting them to clench their teeth or Gendrasic's maneuver, which is getting to pull their arms. Obviously, in some patients, they won't be able to do that. So that's why you have to clench the teeth, if they have a hemiparesis, for example. Hoffman's sign. So this is, again, classic of upper motor neuron lesion. Again, all we're doing now is building up the idea that we have upper motor neuron signs. So what you're going to do is flick. You're going to put your finger under their middle finger, like the gentleman has, and flick your thumb off their middle finger. That is how you perform Hoffman's sign. And then you're looking at their first finger and their thumb. I wouldn't do it this way just because it just doesn't look right. But as you can see, the first finger and the thumb are flexing towards one another. And sometimes you'll get them to make an actual OK sign. But you adjust that flexion, and you'll see it in the other fingers as well. The flexion of the fingers is the sign, and that demonstrates hypotonia again. Babinski's reflex. So is this normal or abnormal? This is obviously abnormal because it's going up rather than down. And then let's have a look at this one. Abnormal as well. Okay. So a downward going plantar is normal. Okay. And obviously this is how you do it. I think you guys know how to do it, so we'll just skip over this one. I don't know if this is true or a rumor or a truma, but just don't use the bottom of a tendon hammer. I have been told it ever since med school. I have perpetuated the potential rumor. Hopefully they will give you a tongue depressor. If not, I'd use your thumb and just kind of like this, just run it up. Apparently this is dangerous. It may cause pain. I kind of can buy it. They're not the bluntest things, but equally I've seen loads of people do it, so I don't know, but just don't run the risk. They may not like it. So these are all the signs that are going to point you towards your answer for question 1. Is it upper or lower motor neuron disease? Then our power is going to give us evidence for question 2. Where exactly is the lesion? And the way we're going to interpret that is by having a look at the pattern of the weakness in the power assessment. Obviously, some patients may have no weakness, and so then you're thinking more about sensation. And so, just have that in the back of your minds. And those are essentially the first 2 questions answered. Is it upper or lower motor neuron? And then is it, what is the pattern of weakness? Where exactly is the lesion? Our coordination and our sensation are slightly different. So coordination, the reason why we switch it around, I think I've mentioned this, coordination, it's important to know if they're ataxic. And if we don't get time to do that because sensation takes ages, and the only thing we're gaining from sensation is knowing whether they have light touch or don't, or whether they have, proprioception or vibration. It's all the same thing, those 3 especially. So it's not worth your time wasting time on sensation when you could get more diagnostically from coordination. The caveat with that is that hopefully, if they are ataxic, you have picked that up before you go to assess them from a finger nose point of view or dystiodotic kinesis. Hopefully, you've got it from their speech. Hopefully, you've got it from the way they are. They may have a head tremor. So again, as I've said, inspection is going to give you all of your signs. You should be able to see, is the patient ataxic before you get to the coordination station. All you're really doing is demonstrating that ataxia and demonstrating to the examiner that you understand what the tests are for ataxia and what the signs of ataxia are. So that's why we do coordination before sensation. So yes. And then what questions are we figuring out with these 2 things? Because as I've said, we've kind of answered our questions from is it upper or lower motor neuron, or where is the lesion? Coordination is demonstrating ataxia, not diagnosing it, as I've said. Hopefully, you've already done that in your inspection. And then assessment of function again. So again, this is not really the reason why we're doing the neuro exam in PACES, but assessment of function is an important part to consider. And that's what we should be considering as physicians. And they will want you to say, I would take an MDT approach with the management of these patients, including thinking about their ADLs and their function. Yeah, so that is, another thing. The sensation assessment, what really are we doing here? Essentially, this is going to help us inform our 3rd question, which is what is the etiology of the issues that we have? So especially in peripheral neuropathy, is it motor, is it sensory, or is it sensory motor? So that we have very different differentials depending on whether there's a sensory component, a motor component, or both. And then the other thing that we may be doing in our sensation assessment is trying to gain further evidence for the pattern of the neurology. So this is where I talked about having a myotomal problem. So maybe it's our ulnar nerve and we have an ulnar claw. And the way to think about your sensation then is the first thing you want to do is figure out, do they have an ulnar distribution of sensation loss? That would obviously make you more likely to say they have an ulnar lesion, and you'd comment on that in your presentation findings. So that's the other thing that you're trying to do. So yes, hopefully that gives you an idea of what questions we're answering when we're approaching these 2 parts of the station. So coordination, again, you want to think about the pattern. Essentially, is it bilateral or unilateral? And the reason for that is that we have very different lists for a bilateral, so an actual ataxic syndrome, or a unilateral, which is essentially a cerebellar lesion, and that is the same as a stroke. So vascular, spatial lesion, MS, that's essentially your list for unilateral, whereas bilateral, you're thinking about drugs, you're thinking about alcohol. It's a very different, heavy metal poisoning, chemos, those kind of things. So that's why we're thinking about pattern. And then obviously your assessment itself is your finger nose testing, your rapid alternating movements. So that's going to be your dystiodotic kinesis, and then your heel to shin test in the lower limb. I haven't mentioned about gait very much. And I will do, I'm hoping to get maybe my old consultant to come and do a session on gait analysis. But the issue with gait, some people do it at the start, and I think that is very useful. And, realistically, it should probably be done at the start. The only thing that I think about gait is that I remember in my 3rd year OSCE, I did gait right at the start, and the patient was very, very immobile. And so it took ages. And so I would probably make a judgment call But equally, if you don't do a gait analysis, it's really important to make up your exam, because how can you comment, for example, if they have a myopathy, how are you going to comment on their waddling gait if you haven't got them to do a gait? So I think it's a bit of a judgment call. My feeling is that you should probably do it right at the start, because I think that's probably what they're expecting. But that is I guess, the risk you run. And maybe I'm personally just a bit burnt by it. So you just got to hope that you're doing upper limb. But yes, your gait and your stance assessment is going to include Romberg's. And we're going to talk about the fact that Romberg's is the test that we're going to use to differentiate between sensory ataxia and central ataxia, so cerebellar disease versus proprioception issues. And then, as I've put in brackets, you may see the patient having nystagmus. If they are really ataxic, they're going to have eye signs, and you may just visualize that on inspection. You don't need to test for it. And equally, hopefully, you're getting them to talk a bit, saying they're not in pain and consenting to the exam. Listen to their speech. Again, it's just to really drill home, inspection is the main thing that you're going to be doing in all of your exams. So finger nose testing, do this to chin if the patient is obviously ataxic. You don't want them to poke themselves in the eye. And you want to have them at the end of their extremities. So when they're reaching to you, they want to have a straight elbow. So you can see this gentleman is right at the end of his range. And you can see that his intention tremor gets much worse as he approaches the target, which is classic of intention tremor. And then dysmetria is under or overshooting, so we call that pass pointing as well. And then the key thing to remember with cerebellar lesions is that obviously they are ipsilateral to the sign of the side of the signs. So this patient's demonstrating their function or their coordination by putting a pen on. Now he's looking more at the left side unilaterally, because previously it was looking at both the left and the right. And you can see that she struggles a bit more with the right side compared to the left.
Good. And now just go from the tip of your nose, the tip of the pen, back and forth. I'm going to move the pen. Okay. Okay. Another hand.
So she's got bilateral signs, but actually on her coordination of the pen thing, I think her right hand was worse than her left, seemingly. But yeah, just interesting. This is your dysdiadochokinesis. So this one looks okay, and then it can't do it on the other side. So that looks a bit more unilateral than bilateral. He does make an error with the first one, but it's not quite as bad.
Pronation movement doesn't occur. So this completely shows that this is dysdiadochokinesia. Now, what are the causes in which it is seen?
Okay. So, and then the heel shin testing, just to give you some examples of how these look when they're abnormal.
This heel, start at your knee, go straight down and straight back up. Just with your heel.
So you can see she really struggles with that.
Okay, let's do this side. I'll hold your leg, just go for your knee. Go down and then try to come back up too, slowly.
So that's very bilateral, I would say.
Fine.
And then, like I said, we're going to try and do some gait analysis in a separate session. But an ataxic gait, you're going to have broad-based, and they're going to appear drunk or unsteady. And the way you're going to really accentuate it is through tandem. Heel-toe is the word. Heel-toe gait analysis is really going to accentuate that. So I told you we'd see a lot of this gentleman.
The last gait that I'm going to demonstrate is the ataxic gait.
He does a very good job.
The ataxic gait, the patient has difficulty narrowing the station, maintaining balance. So typically they'll have a wide stance, is trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior posterior to have a tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, I then try to walk tandem, then I'm going to have difficulty walking.
So you get a picture. I think it's quite convincing. But anyway, so Romberg's test. I hope that I'm getting across, like, you know, so we know these tests, and the thing with PACES is you have to think, what is the question that this is asking? You know, diagnostically, I know the Romberg's test is it sensory or is it central? You know, and that's what you want to be thinking about in all of your tests in neuros. Like, what is this sign demonstrating? You know, where is it pushing me in my decision tree? So that is what we're doing. So the sort of theory behind this is that to make up our balance in our normal physiology, we need our vision, we have our inner ears, and then we have our proprioception. So our awareness of where our joints are in space. So constantly we're having feedback. So I know my finger is here and that it's moving, but even though my eyes are closed. So that is because of proprioception. Our inner ear has our semilunar canals, and that is keeping us upright because of all the fluid in there. And then that means that when my eyes close, because I have those two things, I know my hand is here and I know that this is upright, that gravity is pulling me down. And that's because of my inner ear and my proprioception. The problem is when patients don't have one of these things. So you can get a positive Romberg's in inner ear disease, for example. But in a neurology station, obviously, we're going to be thinking about it in the context of a proprioception issue. So a sensory ataxia. That's what we mean when we say sensory ataxia. That I shut my eyes and then I'll have pseudoathetosis. So this is why, because I don't know where my joints are, because my eyes are shut. And as soon as I can see my hands, I know where my joints are. But this is, you know, what we're looking for. We're looking for sensory ataxia, and this is why you get pseudoathetosis as well as your positive Romberg's test. Okay, so just always bring it back to what is the actual, you know, physiology, and then what is the question? You know, is it central or is it sensory? That's what we're doing with Romberg's test. This is quite a good example.
63-year-old male has diabetes and has difficulty in walking since the last 3 months. He tends to fall while walking. He's got a positive Romberg's test. The Romberg's test, when he closes his eyes, see what happens. Okay.
So I would stand a little bit closer in your assessment than that doctor did, but yeah, that's a nice positive Romberg's test. So obviously, we're not going to assess speech. If you have time, you can say, you know, especially if you suspect cerebral disease, you want to say, can you get them to say baby hippopotamus or 52 West Street or whatever? And the way to describe a cerebellar speech is staccato or scanning in nature. And I think scanning really works in this gentleman's example.
Okay, so can you tell me why you came to the hospital?
Well, about 2 weeks ago, I woke up, I know my body wasn't feeling right. I started stuttering and my words kind of slurred. So like my sentence wasn't like flowing. It's just like a pause and like a brief, like I'm trying to get the word up, but I know the word I'm trying to say, but it's not going out.
I think his description there of it pulsing, you know, that is essentially scanning. The idea that it's not flowing is exactly what we think about in our cerebellar disease with regards to our movements, you know, in other, you know, whether it's the upper limbs or lower limbs, you know, they have intention tremor. It's not flowing. When we look at their eyes, they have, you know, lack of smooth pursuits and dysmetria and overshooting and past pointing. So it's just that happening with the voice. So that's the way to think about it. But he gives such a beautiful description of how he's feeling. Then we have our eye signs. So I'm just going to play this video so you can have a look at how we test for saccades. So saccades are the rapid eye movements that we're able to produce. And we basically test that by getting them to look at the bottom finger, then the top finger, bottom finger, top finger. And then this is how they're going to do it. So you want it slightly apart. And as you can see, this patient has normal saccades. Yeah, that's how you assess it. But other than saccades, you're also going to be looking for nystagmus, and that can be vertical or horizontal. The patient may have like a central head tremor. I think I've got an example of that. And they may have the truncal ataxia. So they may be like moving around in the actual bed. You know, these are all signs that I've seen in my neuro rehab practice. It's fairly obvious. And maybe you don't, you know, I think part of PACES is knowing there's something wrong. And then what you're doing in PACES is learning how to describe that. You know, so you know, before PACES, maybe I see a patient with ataxia and be like, what is going on? There's something going on. But now that I've done PACES and practice these things, I'm able to describe it as a head tremor or truncal ataxia. And it just gives you that nomenclature. And then obviously this patient has very abnormal eyes. So they're asking him to stay straight ahead. And this is what's happening to his eyes. So, and I think the other thing to say is that, you know, often these patients will have many symptoms all at once. So they may have nystagmus, but also lack of smooth pursuits. And so their eyes may, you know, be going absolutely, you know, like this. I'm not sure if that's a nystagmus or if that's, he's also got lack of smooth pursuits. So there's many signs. And I think sometimes candidates get a bit worried, but because many signs on top of one another, it doesn't look like a classic nystagmus, does it? But it's because he's, you know, his eyes can't move smoothly either. So he's got nystagmus on top of that, similar to the cogwheeling example of rigidity on top of a tremor. You know, it's almost its own separate sign, isn't it? So that's just something to think about. And then we have a head tremor as well. So this poor gentleman has a head tremor. That's just to give you an idea. So those are coordination signs. Again, these are separate, and it's not really upper or lower motor neuron. Like I said, we've kind of answered that question. And, you know, depending on the patient, they may have a positive Romberg sign, and that would be maybe lower motor neuron. So I've just ignored that part, but I again will give you an idea of where to find this after the talk. But yeah, essentially, coordination, we're trying to demonstrate that they are ataxic, and then we're also thinking about function. And obviously, the pattern of their ataxia, is it lateral, bilateral or unilateral, is going to inform our differentials. And we think about cerebellar disease, and we think about ipsilateral lesions for cerebellar. Okay. Sensory exam. This is really long, and it doesn't need to be fully done. I think the main thing I want to talk about is the different tracts that we're assessing in the different domains that we're assessing. We are, again, looking for a pattern. Are we confirming whether this is a mononeuropathy? So for example, I don't know the difference in the sensory pattern, but L5 root has a different sensory pattern to a common perineal nerve injury, and that, you know, the sensation may help with that, as well as there being some slightly different, I think it's a foot eversion or something is also different. So, you know, we're building up our argument of this is a mononeuropathy, but also we're trying to see, is this, you know, is this evidence of a length dependent peripheral neuropathy? So if they do have a glove and stocking distribution of sensory loss, then that would add to our you know, idea of this is a peripheral neuropathy, and it's a sensory motor peripheral neuropathy, and that will give us our list. You know, whereas if they don't have any sensation impairment, then it's going to be a purely motor list, and then actually the sensation examination is important. So yes, as well as sensory ataxia, which obviously is proprioception issue. So the main two tracts that we're thinking about are the spinothalamic tract and the dorsal column, which is actually called the dorsal column medial lemniscus tract. And essentially the spinothalamic tract is pain and temperature, and the dorsal column is everything else. So light touch, vibration, proprioception. I think light touch may have some contribution from both tracts. And so actually light touch is probably the worst one to test. Also, it's a bit more subjective. You know, whereas a patient can say, I can feel it vibrating, I can't. Light touch is, can you feel that? And is it normal? It's a bit more subjective. Whereas pain, is it sharp? But is it not? It's a bit more objective. So I would probably put light touch after vibration and proprioception, actually. And I would start with pain and then vibration, because then you're assessing spinothalamic tract and then dorsal column. And actually, if you run out of time, then you can comment and say, the spinothalamic tract and the dorsal column are both intact, but I would like to assess the dorsal column further by doing light touch and proprioception. That would be far more useful than doing light touch and proprioception and being able to say the dorsal column is intact. I haven't assessed the spinothalamic tract. So these are the reasons why we put coordination first. And then when we do our sensory exam, I want you to do one of each and then finish the dorsal column. That's how I want you to do it. Okay. So the things to remember with the dorsal column, the spinothalamic tract, let's do that first. So pain and temperature. This synapses immediately in the dorsal horn of the spinal cord, and then it decussates pretty much immediately. And the way to remember where these tracts decussate is that they decussate where they synapse. Okay, so this one synapses in the spinal cord, and so it decussates in the spinal cord. That's the spinothalamic tract. Whereas the dorsal column, that doesn't synapse immediately. That synapses in the medulla, and it decussates in the medulla. And the way to think about this is where the S is in the words. So spinothalamic tract, that's right at the start. The synapse is right at the start. So it synapses as it enters into the spinal cord, and therefore we know it decussates there as well. The way I remember spinothalamic is SP is for pain, and then thalamic temperature. So you have all of those SPT. It synapses immediately because it's right at the start of the word. Is the S for synapse. Then you have P for pain, and then you have T for temperature. Obviously, this is just the way I remember it. You don't have to do it this way, and maybe you just know these things, but I don't. And then the dorsal column, that synapses later because the S is the fourth letter rather than the first letter. And so we know that it synapses later. Therefore, it's going to synapse and decussate in the medulla. And we have an M in the column to help us remember medulla. This is every other modality. So like I said, vibration and proprioception primarily, and then also light touch, but do that in that order. Do light touch last is what I would do. So hopefully that is an aid memoir for you guys. The only thing I want to talk about here is Brown-Sequard syndrome, which could come up. Obviously, this is a hemisection of the cord. And the question I want to ask is, where is the lesion in this case? So this patient has right leg high tone, so hypotonia in the right leg. The right leg is also weak, and the right leg has the loss of vibration and light touch. However, the left leg has got loss of pain and temperature. And so just taking the information from the sensory loss there, we have right vibration and light touch loss, and we have left loss of pain and temperature. So if we think about the spinothalamic tract, so the pain and temperature tract on the right-hand side, the sensory nerves in the right leg are going to go into the spinal cord. They're going to synapse immediately and therefore decussate immediately because it's the spino, S, spino, P and T, spinothalamic tract. We know that decussates immediately. And so actually the pain and temperature innervation sensation of the right leg is going to be on the right hand, on the left hand side, because it decussates immediately. And so what I'm saying is that the fact that that's intact means that actually, we've lost our left pain and temperature. So if we do it the other way around, we know that leg is getting all of its sensation, all of the sensation is going back up to the brain, decussating immediately and going up on the right-hand side. And so we know that means that the lesion is on the right-hand side, because equally, the vibration and light touch from the right leg is not decussating immediately. It is going straight up to the medulla. So we know that is where the lesion is. The lesion is on the right-hand side. And in general, you have this patch in blue that demonstrates all sensory modality loss at the level of the lesion on the side of the lesion. So that is essentially the way to cheat this, but it's just helpful to think about where the area of cord damage is. So it's on the right-hand side because you can figure that out with the decussation and the lack of decussation in the spinothalamic versus the dorsal column. Okay. These are your mononeuropathies for sensory loss as well. And like I said, this is part of your sensory exam, is trying to build that up. And these are your sensory signs as a summary. So I'm very aware that this is going on quite a while, but this is probably the most important part of it. So just to recap, the inspection is key. The first question is done in the inspection, tone, and reflexes. The second question, exactly where is the lesion in the brain, spinal cord injury, the root, the mononeuropathy, polyneuropathy, plexopathy, all of that, that is your second question. That is mainly from power, but it can be from sensory. And then you also have to think about coordination. Is it central, but also if it's central, is it unilateral or bilateral? But essentially, your first question is those, your second question is power, and then your third question we're going to come onto in a separate topic, because we're going to have, we are going to have figured out from our assessment whether we have a sensory neuropathy, a motor neuropathy, or a sensory emergent neuropathy, for example. So we're going to fill out those lists in separate section. The way that we are going to basically talk about this now is in the way of a map. So our decision tree is here. We are firstly going to outline that we're going to find upper or lower motor neuron signs. Those are going to be all of these. So depending on what we find in our inspection, our tone, and our reflexes, we're going to come out and decide this patient has upper motor neuron signs, or they have lower motor neuron signs, or they may have mixed signs. And we have a separate one for mixed signs. That's things like motor neuron disease, like I mentioned. That's a classic mixed sign, but also things like subacute degeneration of the cord. I think B12 could cause mixed signs as well. So you have a separate list for mixed signs, but we'll come on to that again in a separate one. When it comes to upper motor neuron lesions, we obviously have unilateral or bilateral. So the idea of bilateral being a paraparesis, and the idea of unilateral being a hemiparesis. When it comes to lower motor neuron, I also want you to think about asymmetric and symmetrical. We haven't necessarily named it in this way, but this is how you should be compartmentalizing it. Is we have symmetrical, so that would be your polyneuropathies, your myopathies, these kind of things, and asymmetrical, so your mononeuropathies, your mononeuropathy multiplex. And then, as I've just said, in your asymmetrical ones, you have your single deficit. So I have an ulnar claw, and that's the only thing that's wrong. And I also have sensation loss in the ulnar region. That is a single deficit. And you have your multiple ones as well. And then in your symmetrical ones, so you have a pattern of weakness that is in keeping with lower motor neuron signs. It is either proximal or distal, and that's going to help you build out your differential. And hopefully, by just writing these things out, I know I've said some of these, but hopefully you're also picking up that a symmetrical distal lower motor neuron pattern of weakness is going to obviously be things like polyneuropathies, and that would be more length dependent. These are the nuances that I'm hoping you've started to build up, but this is just putting it all together and giving you a map. So our upper motor neuron signs, where exactly is the weakness? It's unilateral. We're then thinking brain. The idea that we talked about was that if they have cross signs, so they have ipsilateral face weakness, and so they have left-sided face issues, and then they also have right-sided hypotonia and weakness, then we're thinking about the brainstem rather than the brain. Okay, so that's the nuance there. Then if they have a bilateral arm and leg weakness with hypotonia, hyperreflexia, then we're thinking about the spinal cord. That's where the lesion is. And in the next talk, we'll think about what is causing that spinal cord lesion. Okay, so that's our third question that we're going to come on to. But just with these two questions, we're thinking spinal cord injury is where the lesion is. Then this is important, and I hope that I've got this across. But basically, if they have a single deficit, so I've said the idea of the ulnar, but imagine if it's the whole lower leg. The idea that the single deficit could range from the whole lower leg to a foot drop. So you're thinking a common peroneal nerve injury. That is a bit of a spectrum. And what I want to do is tell you that the whole limb, you should be thinking about the anterior horn. We're thinking about polio in that case. And then a myotome, we're thinking about a mononeuropathy. So my brother had a skiing accident. He got a foot drop, and he'd gone through his common peroneal nerve. He had a surgery and he's much better now, but that would be a classic mononeuropathy. So you have trauma, for example, in his case, was the cause of his myotomal loss, which was a mononeuropathy. And then in between, that's where, just want to try and move this. In between, that's where I want you to think about root and plexopathies. And so we're not going to map that because it's just a lot of work. And same with mononeuropathies. You should go away and learn them. But in the map, you know that in that sort of, it's got arrows for a reason. It's a bit of a spectrum from a whole limb to the myotome. If it's not quite the whole limb, but it's multiple muscles, then you're thinking root or plexopathy. Okay. That's how I want you to think about it in your head, just as the map. So Then we come on to multiple asymmetrical patterns of weakness. So we have low tone, we have no reflexes, we have muscle loss, muscle loss, because we're lower motor neuron. Then we're thinking, where is the pattern of weakness? It's asymmetric, and there's actually multiple areas. So we have a wrist drop on the right hand side, we have an ulnar claw on the left, and we have a left foot drop. We're thinking mononeuritis multiplex, and we have, like I said, we have a list for that. It's not very common, and I've already forgotten the list. Diabetes is one of them. Hopefully you guys know what you're talking about. Then we are coming onto our symmetrical ones, and our more distal symmetrical weaknesses are our polyneuropathies, and these are our length-dependent polyneuropathies. So these are your classic glove and stocking distribution of weakness, okay? And with that, we're going to be thinking, do we have sensation loss? Do we have just motor loss, or is it mixed? You know, and that's going to inform our next question. What is the etiology of this polyneuropathy? Okay. And then we also have our proximal weakness. And then the next question we ask with our proximal weakness, because we're trying to differentiate, is the CRDP or is this a myopathy, is do they have reflexes? If they have reflexes, yes or no. If they don't have reflexes, we're thinking about a polyneuropathy that is length independent. So classical CIDP is this. You know, and GBS is probably in between those two, because GBS is a length independent, it's a demyelinating process, it's not a length dependent neuropathy, but it has this ascending pattern of weakness. So it doesn't present with proximal, it ascends. You know, that's why we get worried when it starts to affect their chest and we're thinking about doing all their breathing and do they need to go to ITU? So that's probably somewhere in between, but or CODP is definitely on the proximal side. And if they have reflexes on the proximal side, then we're thinking more myopathy. Then, as I've mentioned, the main questions that we're answering, you know, the main things, the modalities that are answering question 1 and question 2 are inspection, tone, reflexes, and then power, plus maybe sensation. But hopefully, we've already got an idea. Our coordination, so our ataxia, hopefully by the time we get to our coordination assessment, we have an idea of what is going on with the patient. Hopefully we know they have a bilateral or unilateral ataxia just by observing. But the way we're thinking about that is, firstly, is it central or is it central or sensory? And then with both of these, I've only put it on for central, but for both of these, we'd be then thinking about, is it bilateral or unilateral? In central, if it's unilateral, we're thinking about a cerebellar ipsilateral cerebellar lesion, and that would be the same differential as our brain lesions. So our space-occupying lesion, which could be infection, malignancy, our vascular lesion, hemorrhagic or ischemic stroke, our demyelinating process, MS. That is what we're thinking about. Whereas if it's bilateral, then we're thinking about our alcohol, we're thinking about our heavy metal toxicity, we're thinking about our vitamin deficiencies, we're thinking about drugs. So that's a totally different differential. And then I don't think I've done it for sensory, but essentially, is it sensory unilateral? If it's unilateral and sensory, then it's just a you know, a proprioception issue of that limb. Whereas if it's bilateral, then maybe it's you know, more of a polyneuropathy rather than a mononeuropathy. Okay, so that's how you should be thinking about that. And the way we test between central and sensory is the idea of athetosis versus pseudoathetosis, as well as the idea of Romberg's. Okay, hopefully that is everything. Oh, the other one is paraparesis with low tone. Okay, very rare, probably not going to come up, but just so you know, when we talk about paraparesis, we're normally talking about spinal cord injury. That is spastic paraparesis, and you can get low tone paraparesis. This normally is things like bilateral anterior horn. I imagine there is also a list for this, and I must admit it's not top of my own list, but that is something also to think about, is having a symmetrical low tone paraparesis and making sure you have a list for that. But things like spinal muscular atrophy are from bilateral anterior horn disease. Okay, I imagine M&D is probably on that as well, on that list. But yeah, these are the ones that I think are likely to come up in your exam. Brain, spinal cord, polyneuropathy, both length dependent and length independent. I would probably put myopathies on there as well. And then cerebellum, ipsilateral or bilateral. So that's just probably my idea of what to revise. But equally, polyneuropathy is going to come up far more than anything else. And I have talked to many people that have done the exam recently, and they've had polyneuropathy. So just make sure you understand that, and we will go through that. There's bilateral paraparesis again. I've kind of just outlined what I think is common, and I do think that it's helpful to think about what is going to commonly come up. Like I said, we've talked about Chorea, maybe have a think about Chorea, but I would not spend too much time on abnormal movements. It's just helpful to have an idea of where to put that. Obviously, we've not put that on the map because we haven't put things like Parkinson's, we haven't put things like neuromuscular junctions on the map. We're essentially looking at the question of a normal neurology exam, thinking about upper and lower motor neuron signs and where is the lesion in that sense. Obviously, those have slightly different presentations. So they would have neuromuscular junction normal neurology exam with fatigable weakness. It doesn't really fit in that map, so that's why it's not on there. Okay, but hopefully that was helpful. The way we're going to do this is break it down and go through the neurology presentation on Friday, and then we're going to start with the easy things. So the upper motor neuron is the easiest, definitely by far, and hemiparesis is definitely easier than paraparesis, and we're just going to start by doing that. And then we will probably do another session, probably next week, and we will do peripheral neuropathy and go through the length dependent, length independent, but also the motor, sensory, and sensory motor lists. And then we can do maybe rarer ones. So in that, we could do our bilateral, hypotonic paraparesis and our mononeuritis multiplex. I will put out a set of references just so you have all of those videos that you may want to do. There were some helpful websites as well, but I am just going to check if, oh wow, good, I'm still here. I'm very impressed, but that was quite long. I may just stop the recording now. If you have questions, then do put them down in the comments. But I may just stop the recording now, and then I'll take some specific questions now live as well. So yeah, thanks very much.
Okay, guys, if you've just completed that, then well done. That is a very long lecture, and hopefully that was useful. Any questions, do put them in the comments. I will reply to them. And like I said, I'm not a neurologist, but I'm hoping that that gives you an idea of how to think about it, because a lot of you are not neurologists. You're not going to be neurologists. And remember, your examiners are also not going to be neurologists. So hopefully that is useful. If you like the way I teach, if you enjoyed that and found it useful, then we have another one for cranial nerves. And as I've said, we've gone through the decision tree in that lecture, but we haven't touched on the etiology. And so when it comes to the etiology, we do that in our presentation practice sessions. So what I do is I give you a structure, for example, with hemiparesis, what you should be saying, what are the signs you should include, what is important, and essentially you're answering those three questions. Where is the lesion, upper or lower motor neuron? Where is exactly the lesion, depending on the pattern of weakness? They've got left-sided weakness, it's a right-sided brain lesion, and as a result, what is the etiology? Those are the three questions we still use in presentation practice, and then I give you the differentials. Vascular, which could be hemorrhagic or ischemic, spatial-confined lesion, which could be inflammatory, infective or malignant, and obviously inflammatory is your other one. So these are what we do, and that's how we break it down. There are loads of lists. It's really helpful in neurology, but that's all inside the PACES Academy. So make sure you join and use YouTube 15 for 15% off. I think it's a really valuable resource, and also you'll get to practice live. We do these sessions every week. We check in, we have a nice community, so check that out. If you're not interested in that, then I do suggest you check out the webinars. You'll have to sign up and register, but that's completely free, and I'm going to be adding more and more content there and actually tidying that up a bit in the next coming weeks. So that should be much more, I think, useful, and I want to try and make it a bit more streamlined. And I don't want to waste your time talking about the same thing, so I'm going to try and streamline that a bit, but make sure you tune in there. And if you haven't already, then check out my video on my actual exam. I think that is one of the most helpful things. We go through all of these things in detail. It tells you loads about the exam, and you get a feel for what might come up and how I felt at the time. So yeah, check that out. That's completely free. I'll put that here. Check out in the description the webinars, and also join our group. I'll put that up this side. There should be a little link to join our pre-PACES group, again, completely free. But yeah, the best way to get through this really difficult time, in my opinion, is to join the PACES Academy. So do that, have a look at all of our feedback, and yeah, we've done really well, and I really hopefully we'll get to see you in there. Anyway, thanks a lot, and I'm just going to leave you with a testimonial from someone else who really enjoyed the PACES Academy. This is from Holly, so check this out.
super useful for connecting with other people that maybe are on the wards but don't have like a particular revision buddy that they can revise with. It's good to have that space online where you can practice presentations. And I think that was what was amazing about the PACE Academy, is that you can nail down your presentations, and perhaps actually don't always get that in hospitals. For example, Regis might be quite busy in hospitals to actually like tell you, oh, let's just do some presentation practice, because they're busy. Obviously, everyone's got clinical work. But that's what was great about PACE Academy, is that everyone can just get together quite informally and formally as well, do that presentation practice. So that's what I thought was amazing. And I think also just like the teaching that you provide, I think I love like even just like the 10-minute bits that you did after like a capture or like before a capture. It was like, that's such a nice, short, sharp bit of really useful information. But when I remember you doing like the left hand and the right hand thing, I was like, oh, that's really cool. And like, it just 10-minute bursts. I think sometimes obviously people lose concentration doing like hours and hours of teaching. And also the neuro thing, I think that's what really clicked for me actually, when you're thinking, okay, when you're looking at neurology, where is the lesion? And actually was like, I get it. Like, it doesn't really matter if you can't figure out what it is, but as long as you can work out what different things affect the different parts, and having your like diagram of all the things that different affect everything, I was like, that's what was amazing and what really helps. So I think, yeah, that kind of finally clicked whilst doing the PACES Academy.